Welcome everyone who's joining us. The integration of peer support into the crisis continuum of care through mobile teams. My name is Alex. My pronouns are they, them. I'm your care team tech host for today. I'm going to turn it over to Terrence to do introductions for the panel.
Thanks, Alex. And hi, everybody. It's great to be here. Great to see you all. You know, I was watching the chat and I know Paul's from Humboldt, and then Lisa and Juliet connected, and it just struck me because we'll be talking about this today, the need for integration and the need for connection, you know, in this work that we're doing, you know, and that's going to be increase, not decrease, you know, with as we move forward in being able to deliver services in many ways. Our team today from RI is, we have Lisa St. George, who's been with our company since just about the beginning. I was going to use the term, never mind, it's been a long time. And she's the Vice President of Peer Support and Empowerment, and has been a tremendous mentor for myself. And then Wayne Lindstrom, who knows business, he's the VP of Business Development and Consulting, has been in very influential roles throughout his career and across the nation. First, let me go back to Lisa. Lisa, what would you like to add? What more would you like to tell us about yourself?
Well, I guess, you know, I have a 40-year career as a social worker and have worked in many areas in human services before I came to RI. And one of the qualifications that I had that I brought to RI with me is my lived experience. So I'm both a person with lived experience and peer supporter and a social worker. And I'm really happy to be with you today.
Thanks, Lisa. And Wayne, what more would you like to share with us?
Well, I guess I'd have to comment on Lisa still being a youngster, and this is 51 years of my career in behavioral health. I too started out in social work with the military during the Vietnam era. And as Lisa has a rich body of experience, I would have to echo that as well. Before coming to work for RI in 2019, I was the behavioral health commissioner for the state of New Mexico. In another lifetime, I was the addiction commissioner for the state of Ohio. I was the CEO and president of Mental Health America in DC. So I've done everything from clinical work to working in just about every setting there is in our field. So it's good to be with you this afternoon.
Thanks, Wayne. And as for myself, we have a theme going on here. So it's been 36 years for me that I've been in behavioral health and education. I'm what I call a recovering therapist. I worked as a therapist for many years. And then due to my own life's journey, you know, as a peer and a peer with challenges, came into the work of peer support. And I'm the manager of training development for RI. I started with the company as a recipient of services. So recovery and advancement is possible. Let's get right into the meat of things. Wayne, I'd like to talk about crisis service implementation challenges. If you could, from a systems view, could you talk about implementing services? Implementing services can raise many challenges. It's hard. You've done a lot of startups, and so you know that. Could you describe some of the challenges around like reimbursement rates and Medicaid reimbursement?
I will take a stab at that, but I would also like to broaden the question a bit, because the challenges certainly are not limited to reimbursement rates and Medicaid regulations. In many states, it can start with statutes. In California, you have 5150s, which, dictates what happens to people who are on an involuntary status. And in some states, those statutes are very prescriptive about what happens to a person who's been deemed to be on an involuntary status, and who in fact can transport them, and what kinds of facilities they can be admitted to, et cetera. So if there's not alignment beginning with statute and also regulations, also beyond Medicaid, that align with the Crisis Now model and SAMHSA's National Guidelines for Behavioral Crisis Care, it's very difficult and challenging to implement any of the core service elements in the model, including mobile crisis teams. It's curious to me in particular, for those of you that are familiar with the federal parity law, and most states have piggybacked on the federal, what the acronym SMAPIA statutes demanding parity between general health benefits and those for behavioral health. Those parity provisions have not extended to crisis services yet. So if you're in a Medicaid expansion state like California, you can expect that probably about 70% of the folks who access mobile crisis services will have Medicaid benefits. But if you're in a non-Medicaid state, that may be reduced to as low as 40 or 50%. So Medicaid is just part of the calculus in terms of, how do we pay for these services? And if somebody has commercial insurance typically does not pay for mobile crisis services. Medicare does not. Benefit packages like TRICARE for military families, etc. So if there aren't other safety net provisions in terms of a form of payment for those that are not enrolled in Medicaid and those who are uninsured, then any provider who wants to deliver this service is already at a significant deficit and probably will not be able to sustain services. At some point, maybe we can talk about some of the workarounds associated with how to cover some of those deficits. But in addition, when we're talking about Medicaid, Medicaid traditionally has been a fee-for-service payment mechanism. And in most states, crisis intervention has been a code within Medicaid that's billed in 15-minute intervals, and the rates have been historically dismally low and doesn't sustain this service. The other shortcoming in fee-for-service is that a provider only gets paid for face-to-face service delivery. So if you're talking about a service like a mobile crisis team that can involve substantial travel time, there's no payment for that. And often the rates aren't sufficient to cover that downtime when the mobile crisis team might be engaged in an attempt to deliver the service, but sometimes that can be hours, particularly in more rural and frontier environments, or if you're in LA, just getting jammed up in traffic can be a considerable barrier. So I always advocate when I have the opportunity relative to our consulting work with state authorities for behavioral health and for Medicaid to advocate for either an episodic or a bundled rate that can be all inclusive. Because in addition to fee for service at 15-minute intervals being difficult, it is a huge administrative burden if you're expecting to capture every 15 minutes along the way in terms of a mobile crisis team intervention. So mobile crisis teams oftentimes are expected to be operating kind of on a firehouse model, that they're always available 24/7. And if you're in an environment that doesn't have a significant population density, then there's a lot of downtime for those teams. And if you're only getting reimbursed for face-to-face encounters, much of that time is not going to be paid for, which is another shortcoming oftentimes with Medicaid. Accessibility standards can be particularly important, particularly in more rural and frontier environments. And we've done some work with the Oregon Health Authority, and I was pleased to see that they developed a 1-hour accessibility standard for urban environments, 2 hours for rural environments, and 3 hours for frontier environments, and build into their payment mechanism a way to cover those distances and travel time. So I could talk a long time about challenges around reimbursement rates and Medicaid regulations and other things if you'd like, Terrence, or I don't know if you want to move on.
The next question I think is going to combine, with what you're talking about, because there are capital financing, startup, ramp up challenges. You started, like I said, many places, and new teams, are going to experience difficulties there as well, and not to stick on money, but do you have some suggestions? You mentioned earlier you have some workarounds, so if you could, talk about sort of both of those together, because I think they blend into each other.
Well, let me take the latter first before the former. Oftentimes services in most states are organized within counties and municipalities. And because of the kinds of limitations that Medicaid has and the parity issues with regards to other payers, communities have had to be very creative in finding ways to pay for these services for those that don't have a formal payment mechanism. Oftentimes that has involved a local levy tax, if you will, to provide that safety net funding. We operate crisis services in a number of places in North Carolina, and one of those communities, the health systems came together and annually contribute to a trust fund, if you will, to pay for these services, because they found that by their investment in crisis services, that it reduces a lot of unnecessary ED utilization and all the complications that come with that, and also reduces the demand on inpatient stays as well. So there can be a number of creative ways that local communities and counties and states can come together to solve some of these financial sustainability questions. When we talk about challenges for starting up these services, and this certainly isn't unique to starting mobile crisis teams, but the biggest challenge we have relative to whatever service we're talking about are the workforce challenges. We simply, regardless of the particular discipline involved, have a huge shortage that's exacerbated every day, and by old folks like you and I, Terrence, who are aging out and retiring and doing other things. And young people aren't joining the helping professions as they did back in our day. And a lot of it, I think, has to do with the kind of student debt coming out of undergraduate school. And if you've got a choice of looking at a return on investment, am I going to get an MBA or an MSW? It's kind of a no-brainer what choice I'm going to make. So the more that we can advocate for public policy around pipeline programs to begin to educate young people long before they're at high school graduation about the opportunities in the behavioral health field, and in this particular instance around crisis work, the better. The more that we can offer incentives and tuition write-offs and a variety of other things. One of the things we found, in particular in more rural and frontier environments, is that if you can do internships and residencies and subsidize them, 60% on average of practitioners will remain in those communities. Whereas if you wait to recruit folks, it's much more challenging. But if they're trained in a given community, become connected to that community, they're more likely to stay and continue to practice in those locales.
Thanks. Thanks a lot for that. I could listen to you forever. But as far as aging out or retiring, I don't think I can retire. It would be very dangerous. So I think I'll just keep working. Lisa, I'd like to talk with you for a bit around peer integration. You know, I know you and I have had many discussions about where peers could be utilized that they're not being, you know, and part of the challenge to that is integration. So what will be required in terms of inclusion? What do you think will be required to integrate peer supporters most fully into crisis services?
Well, some of it's pretty basic and really so important. I've had the opportunity to start peer programs in multiple places where they hadn't had any experience with peer support in their community or their organization before. And so one of the things that we've learned from those experiences is that helping the staff to understand the role and the responsibilities of peer supporters is especially important, and to understand the kinds of services that they can provide. And to help that staff, everybody has to make a shift from the individual who's coming to work as a peer supporter makes a shift from being in a patient role into a provider kind of role, a service system worker. And the individuals who are in clinical positions have to make a shift with the way that they might have viewed that person before as an individual who needs help and who needs support. And even though you're not from maybe, you know, the same team, like you weren't providing services to that person who's now come to work on your team, there's a certain amount of concern that I've felt from clinical team members over the years of how is this going to work? How will this person be able to manage this? And that comes from training, and it comes from helping them to understand what their role is, and clear job descriptions, and clarity around what their tasks are in whatever position they're in. It also comes from having appropriate supervision. And you know, California's guideline now is it's the best practice to have people with lived experience who have climbed the ladder into a supervisory position and who have taken the training for supervision to be able to supervise peers. But they've also said that when that's not possible, a clinician can do that, but also has to take the required training, because working with peers, you know, we want to elevate them in responsibility. And in order to do that, we can't be working with them as if they're a patient who happens to have a job. And we have to look at them as individuals who have jobs that are real and serious, and that they have a few challenges. And who doesn't today, you know? So it's like we all have to make a shift in this process. And having clear job descriptions is so important and specific to each kind of job that a peer might be doing. So if they're working in housing, that would be a job description that would include knowledge and expertise around the housing market and how to work with apartments and different things like that. If it's about working in a crisis service system, they need training to understand what that role entails. Because there's details and things that even clinicians who've not worked in a crisis service before will probably need training to understand all the ins and outs of it as they go into that workplace. And so just as Peer supporters are expected to work alongside clinicians in mobile teams, as we're talking about today. We would expect them to have the same kinds of responsibilities, except without the clinical view. So they would be there to engage with people and support people and help them with finding services and help them in identifying goals and things that they are trying to reach, and help them to find a way forward, and mostly inspiring them with hope that recovery is possible for them. And the peer is the living evidence of that. So that's what I'd say about that.
I just get inspired by that because, as I do training, and you talked about everybody being trained on how to be with each other. And the other thing that happens when we do that is any sort of hierarchy goes away, and the team is working very equal, because the clinician realizes that those peers have a knowledge that couldn't be gained from books, and then vice versa. Peers learn some very specific things and little intricate things around diagnoses and symptoms, and so when we put those skills together, it's a true, well, as we call it at RI, a fusion. So sorry, I shouldn't go on. I just was excited about your answer. So you talked about integrating peers into the teams, and what more could you say about peer supporters and their inclusion in crisis system services? Any concerns about that?
So one thing that we see nationwide is the pay rate for peer supports at the entry level is often far too low for the level of work that they are carrying out. And that would be especially true in our crisis services, because that takes a higher level of expertise. We will want people who have some work under their belt so that they are prepared for the intensity of the services that they will be providing. And so that is one hurdle that needs to be climbed across the country. And the other thing is that training, so beyond peer certification training, into training that specializes them in different areas of expertise. And I know in California, come next January, they're going to begin integrating peers into crisis services, and that will be an additional expertise that they can take on along with housing and forensics. And so all of those things are important and contribute to the well-being and the strength of that peer on the team. In addition to that, teams, there's not a lot of accommodation that needs to happen for people with lived experience who are coming in as peer supporters on your teams. But if, especially today, if someone has a doctor's appointment on Thursday at 2:30 and that's the appointment time for them, our service system needs to understand, and the teams working with them need to understand that that's an important part of their well-being. And just as we wouldn't stop someone who had to get a physical checkup for their diabetes from going to their doctor for that visit, we wouldn't want to get in the way of a peer supporter who has therapy or who has to see a doctor. And so that becomes an important accommodation for them. And my experience is that people are very responsible around that. I've been for 23 years working with hundreds and hundreds of peers and teams, and they've always been very responsible about taking care of their well-being and doing it in the manner that least affects the team. And then just, again, I just would emphasize, consider them a full team member, and hold them with respect and honor for their lived experience. And as Terrence says, you can't get that kind of experience from a university degree. It is something that people earn. And, I call it their deep wisdom. They gain their deep wisdom and that unending well of compassion that we value from peer supporters so much by that lived experience in sort of the school of hard knocks. And so it's important to embrace that and to value that because it's been hard won. So those are the things that I would say about that.
Thank you. Thank you. I really appreciate the holding people as equal employees, where it's about being a human with a job, you know, and then the considerations we would give any employee, you know, who's taking care of themselves or has a need. And especially not seeing peer support specialists as patients. You know, I see that all the time, and you're not going to move forward or find the, as Lisa said, the wisdom in that peer specialist if we see them as patients. So thank you for that very much. I want to switch over to mobile crisis team models and ask Wayne. There are three types of mobile crisis teams. Typically, there's co-responder models, each with various disciplines. Could you share about those three models and briefly discuss why the Crisis Now model is the preferred?
Sure, I would be happy to, Terrence. I guess the first thing is I would challenge that there's only three. When we talk about co-responder models, those can take on various forms. Most commonly, it's a law enforcement officer with a clinician. And I might mention that in 2016, the University of New Mexico did a literature review on studies of mobile crisis teams. And they found that co-responder teams involving law enforcement are some of the most expensive and may cost 2 to 3 times as much as the model that we advocate for, and doesn't have the same degree of effectiveness. But I'll come back to that in a moment. Another co-responder model that seems to be gaining increasing traction is to have an emergency medical technician, a paramedic, and a clinician going out. One of the advantages of that model is that they're not going in a police car, nor are they typically going in an ambulance. They're going in an unmarked vehicle and in civilian clothes. And one of the downsides of co-responder mobile crisis teams involving law enforcement is that when you have a police vehicle, an armed officer who's uniformed, present with somebody who's having their worst day, it is not a calming influence. If anything, the presence of law enforcement personnel heightens one sense of anxiety and agitation and can further escalate what's going on wherever a particular crisis may be occurring in the community. That's lessened by virtue of having an EMS or an EMT present with a clinician, because if there are complicating medical factors, for example, if somebody's having palpitations, etc., they can intervene and have medical expertise that a behavioral health clinician wouldn't have. In the Crisis Now model and in the national guidelines, the model is to pair a clinician with a peer support specialist, the person with lived experience. And that's a model that we practice here at RI. And I like to say that having somebody with lived experience as part of the team is the secret sauce, because there, in reality, nobody better to meaningfully engage somebody than somebody who has lived experience, and I think can facilitate a de-escalation in a humane, compassionate way that other personnel, including clinicians, can be challenged by, quite frankly. Here in Santa Fe, New Mexico, which is where I am currently and where I reside, they have taken this model a bit further, but don't include peers, unfortunately, and it's in one vehicle, it's unmarked, but it includes law enforcement, an EMT, and a clinician. So these can take various forms in different communities. And we talked earlier about Medicaid as a source of payment. And California is one of the states that received a planning grant that can qualify California, and I believe this is going to go to effect in January as well, where California can get an 85% federal match for mobile crisis services. So basically, the federal government will be paying the bulk of the cost of services for mobile teams. But if it's a law enforcement officer, that financial burden rests with the municipality that's involved, or the county if it's the county sheriff, or the state if it's a state trooper, for example. So again, the financial burden on a state or county municipality is significantly less if you're talking about the model that we're advocating for. I wanted to mention that a number of states are adopting what's called MRSS, which is Mobile Response and Stabilization Service. And this is a relatively new model. New Jersey, I think, was the first to pioneer it. Ohio has implemented it. Oregon and New Mexico are both in the process. And this will involve a clinician and a peer, oftentimes a family and or youth peer, as part of the team. And the intervention can last as long as 8 weeks. So it's a much more extended model to meet the needs of children, youth, and families, and meeting them over the course of that time in their natural environments, if you will.
Thank you for that great outline of the various models. And so taking from all of that, which components do you feel are the most necessary to create a stable and sustainable mobile crisis team?
I might come at that question a little bit differently, because I think one of the most critical elements when you're planning to stand up this service for the first time is knowing what your capacity needs are. And I wanted to point out that RI established a capacity calculator for crisis systems that includes being able to calculate the capacity needs in a given community for this service. McKinsey and Company just this year took that tool and fully automated it. So it's not a spreadsheet tool any longer. And if you go to crisisnow.com, that calculator is available at no charge to anybody who wants to access it. So if you don't know how many mobile crisis teams you need to stand up, that can be a potential failure right out of the gate in trying to stand up the service. It takes roughly 4.3 teams, mobile crisis teams, to be stood up to cover 24/7 operations of mobile crisis services, 7 days a week, 365 days a year. If you're in a more rural or frontier environment, that would mean paying 4.3 teams for 24/7, 365 coverage. And in some of those environments, they might not deliver a service in an entire shift. So it's important to understand exactly how many teams will be utilized, the peak periods of utilization. And in these more rural and frontier environments, it may mean adapting the model to not having teams in a firehouse model on standby, but instead to have them on call, and that you can pay contingent staff, if you will, to respond in the middle of the night or the weekends or whatever, from home or wherever they may be, as opposed to sitting idle and being salaried to be a part of a mobile crisis team. And I have to frame this whole business of establishing this service in terms of 988. And I don't know how much 988 content participants in the conference have received today. But July 16th is only, 30 days away or less. There's when 988 goes live. And it's not just about having a crisis call center that operates 24/7, but we really advocate that those crisis call centers also be able to dispatch mobile crisis teams, and to the maximum extent possible, be able to divert from 911 and law enforcement responses to people in crisis. And in order to be able to do that kind of dispatch requires being technology enabled as a call center and be able to have GPS technology, bed registries, outpatient scheduling, etc. So I don't know how we're doing on time. There's a lot more I could say about that, Terrence.
I appreciate that so much, Wayne, but I think we need to move on. I'm watching the clock. And the next questions for Lisa are really crucial ones in my mind. So Lisa, you mentioned you've started many peer programs for many different types of services. What roles do you see for peer supporters on a mobile team?
I think that peers belong in the entire continuum of care for crisis services and the behavioral health system. But I think, one of the most important gifts that they bring wherever they are is their ability to connect and engage with people, and their ability to build trust and rapport very quickly. Because once that individual understands that peer gets it, gets where they are, gets the struggle that they're having from a deep level, they can feel more comfortable around that person and know that there's someone who's helping them, who's not looking at them like an other person or somebody who's very different. And so it's really important to have the peers there to sort of break the ice, but peers also have a responsibility to then link that person back to the rest of the team and build that bridge. So, it's not that the peer will come in and run the whole show. They have to, build that rapport, build that relationship along with the clinician, but help that trust, and then be sure that they are linking that and building trust with the rest of the team. And that is in any service that they provide throughout the service system. The other thing that peers are really good at is asking clarifying questions when an individual might be describing something, because they have a deep understanding of what an experience might be like for someone if they've had something similar. And the other thing is sometimes they can help with the individual explaining things to them in a different way than they might to a clinician or a doctor. And again, that peer has a responsibility to bring that back to the team for information and help for that individual. And there's a lot of thought about, should peers tell everybody what the person tells them? But in this kind of a situation, that's an emergent situation where someone's life is at risk, we need to have good communication. And the peer would not do that behind the person's back. They would help them to understand that some things that they might tell them, they need to communicate forward. So it's not to catch somebody, and it's not to fool them. It's to help them to have trust. And the best way to build that trust is by being honest and sincere with an individual. And so, with peers in our crisis services, they're the first person that we want people to see in our fusion model. And it is because of those engagement skills that people who are acting in peer roles have. And I would also add that if we're going to provide trauma-informed services, peer support is a required part of trauma-informed services. And many of the people that we serve in all of our service systems have huge trauma histories. And so without peer supporters, we might think we're doing trauma-informed care, but we're not, because they are required to provide trauma-informed care.
Thank you. In many ways, you answered all three questions. Is there anything else you would add to that, like, you know, the necessity of peers on the team, or the peer supporter clinician relationship?
Well, I think that the peers and the clinicians must develop a trust in each other, and there can't be kind of an us and them kind of thing. And I also believe that, you know, there will be times when police have to come to help because someone's at risk to such a level, or others are at risk because of that individual at a high level, and police need to come and help. And what studies have shown is that when we all work together, the police, the clinicians, and the peer supporters, people have the best opportunities to get a good result from that. And we all learn from each other. So our gifts transfer to each other, and the things that we each bring that are important to that relationship are helpful for us to understand about each other. Because if a person is in need of police support or ambulance support, we have to be willing to work with those team members and to walk alongside them as much as we are working with the person, because we can't exclude anyone depending on the level of need that a person has.
Excellent. Thank you, Lisa. And we have some questions, but I'd like to get to the additional questions for you, if you don't mind. Why must peer supporters and clinicians have a strong understanding of the service system if they're going to be part of a team?
So, I mean, they have to know what's available to people. And you know, so one of the most important things, and I think that people who've been working in service systems for a long time understand this, but when you are in the field with someone who's, you know, and visiting them with a mobile crisis team, and perhaps they just need services, you need to be able to supply those on the spot and to get them to the numbers that they need, even if you know people for them to call and talk to when they call these places, it will help break down barriers. And often peer supporters will follow up with people after a crisis experience with a mobile team, or even in a crisis facility, and ensure that they have what they need, they've connected with the numbers that they've been given, and what else do they need to support them. And that's sort of like that peer bridger model that we saw out of New York State, that's been so beneficial in helping people to follow through on appointments and things like that. So peer supporters are really important in that process also.
Okay, and thank you, Lisa. And one last, I think, very important question is, what are some key areas that everyone, all people working with a crisis system, need to understand, regardless of their role?
So to me, if you don't mind if I jump in, you know, I think one of the most important things is that we need to understand there is no us and them. There's only us. And any of us, any day, could end up in a situation where we're having the worst day of our life, the worst moment of our life, and we don't know that we can keep going. And that is what levels the playing field. And I think from COVID, we've all learned a lesson that all of us are in a vulnerable position in this life. And so we should never, ever assume that that will always happen to those people over there. And when we do that, and we start to look at us as we, instead of, you know, them, we can help the stigma and the, you know, resistance that people have around getting help because of the stigma go away, because it's not helpful to people, and it blocks people getting care until, a lot of times, until they're in their worst moment, when if they wouldn't have had their own, you know, internal stigma that's coming from the messages that they receive from ads on TV and things all the time in the world around them, they would have gotten help earlier because they were uncomfortable, or they knew that they were getting way too sad, or other things were happening with them that were were unlike how their life had been before. And so taking away that stigma will break down that barrier of help seeking, and hopefully, reduce the interactions that people have with mobile teams and crisis, because they'll be willing to identify that they need help long before. This is really, it's heart work. I always say it's heart work, HEART, heart work, and it's hard. And we need to be committed to the services that we're providing to people in order to diminish the stigma, to help people to feel comfortable to seek the services, and providing it in that person-centered, person-directed model that allows people to keep their dignity, have their voice, not step into learned helplessness because we're doing everything for them, but help them to be a participant on their team, and in fact, the leader of their team, and guiding all of us as we support them to their strongest well-being that's possible.
Excellent, excellent. Thank you. And Alex, are we at Q&A time?
We sure are.
Okay, so I turn it to you. I want to thank Wayne and Lisa for their wisdom, and we could spend all day with them, I believe. But thank you so much for your time and being here.
Absolutely. And Michaela, I'll turn it over to you to address the panel questions. Or sorry,
Great.
the question.
Great, thank you. So the first question we have was coming from the chat box, and that is, have they discussed peer support for those with private insurance? Do they provide services, and do they get reimbursed at all? Would anyone like to touch on that?
Well, it sounds like a Wayne question.
I'd agree.
Actually, I'm working with a couple of health insurance providers right now to help them understand peer support. I don't know that's going to happen tomorrow, but I'll let Wayne take over from here.
Well, I was going to answer in terms of mobile crisis teams and not specifically to paying for peer support work. So the overwhelming majority, in fact, I've never found one yet in terms of a commercial payer that pays for mobile crisis teams, or quite frankly, the other core components. We sometimes will get some of the clinical services in our crisis stabilization centers, professional services paid for by commercial insurance, but that's pretty much it. Our belief is that crisis services are a critical service, not unlike 911 emergency medical management services, and they have to be available to anyone, anywhere, at any time. And that whether they have the ability or pay cannot be a barrier, cannot be an obstacle to people being able to access services when they're in a crisis. So that's why, until we see either new parity legislation at the federal level, or we see state superintendents of insurance at the state level enforcing parity at the state level, we have to find other ways of covering these services when people either don't have health insurance or when they have commercial insurance, et cetera. And I think it's an absolute crime that the public taxpayer ends up having to pay for services that have private health insurance. And so I'm hoping that as time goes by, we'll all be holding private insurers' feet to the fire with regards to covering these services.
Thank you so much. The second question I believe you addressed in the chat, Wayne, which was about the MRSS acronym. So I'll move on to the next one. And we have a participant asking for you to please speak on training for mobile teams that support safety when being deployed into situations with limited information available to responders.
And that might be a me question.
Okay.
So as the manager of training, And I know Lisa has much more insight to this as well, but in the training and particularly virtual training, we definitely have to remember that the person is by themselves and their mind is going in all kinds of places of what might happen. So the training model we utilize is many role plays and small group discussions. But it definitely is, Paul, it definitely is discussed and, facilitated that how are you staying safe? What do you stay safe? And then, what you do as a debriefing perhaps afterwards, and when is the right time to do that debriefing? But safety is absolutely first throughout all the, the training. And the reason I singled out virtual, in person, very often just having other people in that energy in the room, people feel safer. But the trainer has to really think about our people feeling safe in the training when it's a virtual training.
Can you say a little bit more about the content, Terrence? I think that's what the questioner was really looking for.
Part of the content, for instance, is we talk about, as part of a test question, we talk about, when you arrive, do you, just pull your vehicle into the driveway and go up to the door? And the answer to that is no. You park on the street with a little bit of distance, and that's to ensure that you are able to get away if need be. And the same goes with positioning. We talk about positioning yourself in a home, and not having the folks in crisis and their supporters between you and the door. And I remember, when I was being trained, when I was in school for counseling, I remember them saying, set up your office so you have an escape route. And at the time I was like, what do you mean escape? These are people, but these are also people in crisis and people who will do things that they otherwise wouldn't do. So we discussed their personal safety, their positioning, and then individually, we've been training people from all kinds of agencies, what being mindful of what the safety training is in their agency, and is it no force first? That's our preference, and no, laying of hands on. And, it was mentioned that, sometimes we need to call the police, and if they're coached well, calling the police, as far as the peer support specialist or the clinician goes, having to call the police is not a sign of failure. It's a sign of insight and success. And we have to, take a look at that. And the other, one last thing, sorry, but I've heard this from staff a lot, about their concerns, and we're in crisis and crisis and crisis. And I said, so when you're driving to work, what are you thinking about? Well, crisis. So how much of that are you bringing in? And we might all have had the experience of when a person was in crisis, the staff or supporters actually made it worse. And looking at that, and it does, Wayne, it includes trauma competency, escalation, de-escalation. We have all of that. I'm sorry, I'm feeling a little pressed for time. I could go on and on about the training. Lisa, do you want to add anything to that?
Oh, I think just continuing on with what you're saying, but like the way you hold your body, the expression on your face, and how we, approach people and keep distance and give people space are all important parts of that. And your organization will have a safety training, be it CPI or something else, that will help you to prepare further for how to engage with people who are really struggling. And I think that we have to be attentive, and I think it's sometimes people are in a situation where it is unsafe, and we need to recognize that. And and be willing to work with the police and engage with whoever needs to be involved to help that person in the best way possible, because what we're trying to do is preserve their life and our lives. And I think that, you know, I've talked to our crisis mobile team provider here, who does include peer supporters, and they answered thousands and thousands of calls last year without any incident, you know, that put someone's life in danger, that, you know, of a provider. And so I don't want us to go into this thinking those people are dangerous, because then we're perpetuating the stigma. Most of the time, individuals in crisis are in pain. They are in sorrow, they are struggling, and the way that we approach them can either create success or failure in that engagement with that person. And I think that peer supporters have such a key role to play in helping that person to feel safe and understood.
Thank you for that. And you had mentioned earlier, Lisa, that the peer specialist takes the lead in the relationship developing.
Mm-hmm.
And I think that's part of why we don't have so many incidences or any, you know, real dangerous situations, because folks, you know, are connecting, and there's an immediate calm that comes. So we don't get those sort of really dangerous behaviors. Like Lisa said, the team, you know, had nothing in a year. So.
Great. Thank you all for touching on that. Alex, do we have time for one more question, or do we need to move on to polling? Is RI using CPI as a part of their training, at least in the verbal de-escalation part?
Part of the answer to that is it depends on what state you're in.
Okay.
Seriously, it does. You know, what is allowed or what is required. You know, so we have different interventions in different places.
And one of the tools that we're using newly, in addition to CPI and other trainings, is a tool called Ukaru. And the training for Ukaru is based in trauma-informed care, and every way you stand and move is based in trauma-informed care. And so that would be something else to look into, because we found that really helpful.
Thank you so much. Yeah, shout out to everyone, our participants, for being here, and our panelists and moderator, and of course the tech team supporting.